Okay. So, video diary with Fred, where it's now the 10th of May. Right, Fred, you wanted to have a chat about things?
Yeah, definitely. I think, well, last time we had to go with a new appliance to get some expansion.
Yep. Well, this was following this one Moon's expansion screw.
Yeah.
And the screw widened, but it didn't seem to have any skeletal effect.
Yeah.
Now that's you're one of 5 people whom I've used one Moon's appliance, and I didn't get any skeletal effect on anyone.
Yeah.
Now I'm not knocking the appliance. I mean, I haven't been on his course. I don't have the time to go and do a sort of 4 weekend course, 1 part in America, 3 parts in Spain at the moment. Yeah. So I don't know if I'm doing things wrong, but 5 people, we put good screws in. We put certainly some good screws in for you.
Yeah.
And we didn't get any change at all.
No, not at all really.
I was surprised with that.
We did that X-ray as well, and there was just nothing.
No, we didn't get on the palate.
I mean, I could feel it. You could feel those forces being applied. Certainly, when I started to come back down as well, around that area, you could feel that it had applied force, but it just hadn't.
No, and you didn't feel any nasal cavity,
no
nasal airway
no changes, no.
Okay, so what are your questions today?
Well, I think that knowing, having had an MRI scan for my problem of breathing dysfunction, having had a septoplasty which didn't do anything, actually made everything worse. And really understanding the situation I'm in, and knowing that I'm not really having, inflammation or anything like that inside the nasal cavity, and knowing that my restriction in my breathing is solely based by the spatial restriction.
So, to sum it up, you say it's structural, not inflammatory.
Yeah. Cool. But also, what's interesting is that, of course, the way in which those symptoms will manifest themselves are exactly the same as any other cause, because if you're ill, you're ill because you can't breathe properly. Those symptoms of fatigue are the same, except it's a different cause. And so I think that for me, I want to try expansion again, because I just know that unless we do that, I'm never going to be able to breathe properly again. And I'm not happy with having people recommend surgery removing and excising internal parts of my nasal cavity instead of addressing what is quite a clear problem. And it's quite clear on the scan. It's quite clear if you compare dimensions to sort of standardised anatomical norms which do exist.
Well, a lot of those I would say were quite modern norms as well.
Exactly, yeah. So that, of course, if the trend is going down, no one is saying why is it going down. I've seen that in a few studies. The sort of the parameters of the front of the nose seem to be decreasing by a few millimetres over the course of sort of 30-40 years, and no one's questioning how that's going to affect the volume of airflow, breathing function. Are we getting smaller as humans? No. So therefore
we're getting taller.
Yeah, exactly. So our kind of, we're not changing, but the parameters of how we breathe are. And of course,
I presume you get to a crunch point, and at that crunch point it starts becoming difficult.
Well, they know at that crunch point it's just acceptable that everyone in the future will be mouth breathers.
Or one of the theories I've contemplated is that a certain amount of inflammatory response is normal in everyone's nasal cavity.
Yeah.
And as the structure becomes more and more limited, we reach that crunch point when that normal physiological level of inflammatory response leads to a nasal obstruction.
Oh yes, because
and that's when I look at the dramatic rise in nasal obstructions occurring, I wonder if that argument has some validity.
Yeah, I would say so. Certainly for me, I just know from my experience of before the operation that when I could breathe, it had nothing to do with the turbinate and this indication of inflammation. It had everything to do with the space around it. And so I now can't breathe very well, but it's not because their turbinates are inflamed. They are the correct vascular level to function. They have a very important function, and actually there are a lot of reported cases of people who've had things done to the turbinates and to that vascular structure, and then they complain of not being able to breathe, because of course you're changing the physiology of the nose.
Well, one could argue you're graving more structural space.
But you're not doing it in the sort of the humane way, because if you're removing that sort of aerodynamic structure by eliminating some of its surface area, air's going to go in, and what happens is it's supposed to speed up as it goes through the nose, and obviously, like a moving train, you get this area of low pressure behind it. It's drawing air in, and so you actually, by the turbinate acts to create more patency by creating some resistance. And so realistically, the best way to improve breathing is to widen the nasal cavity, because the turbinate will take care of itself and it will do what it needs to do in order for you to breathe.
Yeah. If you widen that cavity.
If the cavity reduces in size, I haven't seen any research to indicate the turbinate sort of dissolves, changes. It just, as far as I can tell, it curls up inside itself and gets, stuck in spaces it doesn't want to be.
Okay, so what was your thoughts now? I mean, would you want me to take an impression with a view to creating a slightly different designed, a TAD-based skeletal expansion device?
I think so, yeah. I think at this stage, as I discussed with you earlier today, having spoken or tried to indicate my problem to some maxillofacial specialists and not even getting acknowledgement of the problem, that I think that's, I'm not, in all likelihood, I'm not ever going to be able to breathe effectively through my nose unless I try and achieve some form of expansion. So realistically, I would like to try again.
I would. Clearly, the same risks come again. I don't want. What I'm concerned about is just, if you don't succeed, you just keep on bashing. That can be the wrong way of going about things. We'll take some moulds today for your teeth. We'll probably place those separators in.
Okay.
Now, as I described to you before, I'd like if you've got a what they call drill.
Oh yes, yeah.
Maybe I'll give it to you so you can open up the hole. So we'll solder over, or we'll solder right round the screw points.
Okay.
And if you can open them up, and we'll have to look in your mouth to see what direction of insertion I want to put those screws in.
Yeah.
So we'll get you to open those holes up nicely.
Okay.
And we'll come up with a clever design. I would want to take another set of X-rays of your roots on your teeth just to check that's all right. I don't think I need to take another X-ray of your palate, because we know it's closed. We know it's closed before and after the last stage of expansion. But once we're into the expansion, I'd like to take another check with that. Check that's going okay. We'll take some photographs again. Particularly upper arch, looking at the gums, and the gums look healthy, but I want to have a nice good record of that to check that's all going fine. Now, Fred, one thing I do, we're going to need to put you with the neck gear, which I think is good. But I do want you working on just getting that neck up like that, Mackenzie chin tuck, and a little bit of shoulder work. So I get your neck up. I think that's really quite important as well. And that could take some hard work. Right? Anything else?
No, I just think that's it really. I just think that I think there has to come to a point within the sort of medical profession that they have to sort of broaden their horizons a little bit.
One thing, you've done the NCR, haven't you? I think that's quite useful. One thing that I have noticed is nearly all of these screws, these tabs, become loose fairly quickly.
Right.
So what I would rather do is put all the appliance in your mouth, get you going with the neck gear, get the tension pushing, all right? It's like the horse, on the starter gate, pushing, ready to go.
Yeah.
Then when we're ready to do the expansion, when you've got some NCR booked in, you know where you're going with that, then we'll put the screws in and go with it.
Yeah.
But I'd rather not put the screws in anticipation of when it's going to happen, because they do start becoming loose. I mean, the body will take the bone away around the screws, and they'll quickly become. I'm shocked how quickly they become loose.
Yeah.
You know, I took yours out without anaesthetic, didn't I? And I've been doing that routinely. And sometimes I'm taking them out with a pair of tweezers. Yeah. They shockingly become loose, and you think, well, what effect are they going to have when they become that loose?
Yeah, exactly.
I mean, the alternative is you have osseointegration, so you use a sandblasted or acid etched, acid prepared titanium screw that binds with the bone, but then you can't get it out. So you're between these two levels, and other people have had screws that have osseointegrated, and it can be quite a pain to get them out, and it's quite damaging as well. Yeah. So I think there will be a huge advantage, literally, from immediate loading going straight away. But of course, this time we're going to have those screws up at a 45-degree angle.
Which I think is better.
From the results I've had, we've seemed to get a better result. This is following this concept that I learned with Mariana Evans in Philadelphia.
I think why?
Or Newton.
Well, I think it's because that if you're putting screws right up into the roof of the mouth, but particularly of a mouth that is highly arched, you're trying to move the arch in a way in which it doesn't really want to go. Because realistically, actually, if you look at the nasal cavity, it's sort of it's shaped like that. And then as it arches, obviously that floor pushes up, and so trying to move it from that point up right there, rather than at the sides, and allowing that arch to sort of form how it would have.
Yeah, I mean, it's interesting. I don't know whether the arch goes up or down. I mean, it depends where you take your reference point. I would be fascinated in this, but clearly, as we get more CAT scans and we look at real good change, it will answer these questions, and I probably should go back to some base research on that. But one step at a time.
Yeah.
So we're going to have the screws up at roughly 45 degrees. Maybe a little more inclined, but clearly that you're going to get a lot more oomph. I mean, if you have a stake that's vertical in the ground and you push it, it's going to lean a little bit. If you have a straight angle at 45 degrees and you try and push it up, you're going to face a lot of resistance.
Well, particularly if you've got 4 at different angles, you know.
Yeah.
Well, it's near enough as we can get.
Well, okay. All right, and then we'll gently report back and keep our log going. And I'm going to put this one live fairly soon.
Yeah, sure.
So we want to catch up with these logs so that we're, I think that my concern with much of the medical community is that they're only showing the good cases. And the problem with only showing the good cases, it's showing bias. You don't really learn. You learn from failures. Yeah, and this will be the 3rd time we've tried expansion on you. That's why I need a good set of nice X-rays of your roots before we, a nice baseline check to check we've not caused any damage there. And your gums as well. Okay, well that is a good plan. We'll go with that plan. We'll take the mould now. We'll put the separators in. So when this comes back, we can put the separators in. When the thing comes back, I might get you to give me a hand at drilling some nice fine holes. Okay. So they're held quite nicely.
Yeah.
And we'll report back as we go.
Okay.
All right. Okay.